Dr. Myers. Thank you so much for joining us on TNT Open Mind Insights. You have a wealth of experience that you can share with us, and some really interesting combinations of experiences with your board certification in endocrinology, psychiatry, internal medicine, and also the work that you're doing in the space of DEIB, diversity, equity, inclusion, and belonging. So I'm so curious to see how all of these come together and inform one another. Thank you so much for coming today.
Thank you for having me.
Yes, so the first question always for me is, why have you decided to dedicate your life to improving health and equity for others in our world?
Yeah, I think it starts with just my own lived experience. Diabetes runs very heavily on both sides of my family, and I've unfortunately seen a lot of the negative effects of diabetes. So it was a matter of on my dad's side, I had a cousin, started with her losing her toe, then it became all of her toes, then it became her leg, and it just really was a lot to see someone that I cared about that was such an important part of our family, a cousin. And she started to lose her mind as well, just because she wasn't taking care of herself. She didn't change her diet. She wasn't always taking her medications. And so when I see my own patients dealing with the same things, rather than passing judgment, I realize that having diabetes is a lot of work. Granted, if you take good care of it, it's a lot less work, but it's really hard to try to tell someone in their 40s, their 50s, or their 60s, oh, you have to stop eating these foods, or you have to cut back on how much you eat this, you need to start exercising. A lot of that can be really overwhelming when you haven't lived that type of lifestyle. And for a lot of patients that I take care of in the Bronx, a lot of them are working multiple jobs. So good luck in trying to get them to get time in to try to exercise or being able to eat the way they should be, because they're balancing working all these jobs, paying bills, living life, being a caregiver for children, significant other parents, and it's a lot. So I did this because I think this is helpful to have an understanding, providing the empathy for patients that are dealing with a lot of these difficulties, a lot of these social drivers of health, as we call it, whether it be poor access to care, issues with transportation, low socioeconomic status. And again, having experienced it, seeing it in some of my family members, I think it allows me to understand people in a way that some of my other colleagues may not.
Yeah, that makes a lot of sense. So, how do you help someone with diabetes or support someone with diabetes when they have all of these pressures that they have to do other things and take care of their health? What can you do?
Sometimes it's just listening. Sometimes patients will just say to me, I come to see you because you're easy to talk to. I come to see you because I feel like you understand me. I think sometimes it's just as simple as listening and understanding what they need, how you can help them, understanding some of the local resources. It's really important to be involved with your community. So it's knowing what are the community groups, the CBOs that patients can refer to, what do we have within our health systems in place to help our patients. We don't have a social worker in our clinic, unfortunately, but at least I know where I can turn for some of these things, because we do have a community group within our organization that often meets and sends things out and keeps us abreast of the different programs. So those are the basic things that you can do for someone. Listen and help them find resources.
That's a really important point. And I don't know, is that common for a lot of physicians to look at it that way, where they're connecting resources or taking on that level of responsibility to connect people with other forms of support?
And I think that's the beauty of being dually trained in internal medicine and psychiatry, because I look at the entire patient. I really appreciate what George Engel was doing when he said we shouldn't be working in silos, that a lot of the medical issues and the psyche issues go hand in hand. So if you're only addressing one and not addressing the other, you're actually going to be defeatist, because you're not going to be able to have these medical issues improve if you're not addressing these psycho and social issues that patients have going on. So if I have a patient with food insecurity, how are they going to get their diabetes well controlled if I'm ignoring them?
Yeah.
Some of our patients that are dealing with being undomiciled or homelessness may stay in a hotel or a shelter where they don't have access to a refrigerator, and you have them on insulin. How is their insulin going to stay good if they can't keep it in the refrigerator. So all of these mitigating circumstances need to be accounted for when you're coming up with a treatment plan.
Yeah, and then can you talk a little bit more about what, how food insecurity, whether it's severe or even, moderate, how that affects the ability to control the diet and your health?
Right. So when we are teaching people with diabetes how they should eat so they can have great glycemic control, prevent complications, one of the things we tell them is you should not go more than 4 to 6 hours without eating. Because when you don't eat, it'll cause changes in your body that can cause your sugars to drop dangerously low. Then your body's offset will be to release hormones that raise your sugar up. So people will mistakenly think, oh, if I'm not eating, my sugar is going to be fine. But a lot of times their sugar actually can, like I said, drop and then go up, which can be dangerous because say you have a patient that works as like a bus driver or a taxi driver or a teacher or any job where they're around people and having to provide services or operating heavy machinery and they pass out because their sugar drops from not eating. That's going to be a problem. So it's really important that we don't poo-poo addressing food insecurity. And even if it's a matter of having a list of local food pantries, local churches, or other community centers or organizations, it's really something that we need to really think about when we're taking care of our patients.
Yeah. So what do you do when someone, say, doesn't have a refrigerator to put their insulin in?
So in some cases, we unfortunately would have to give them pills.
Okay.
Or you could try to work something out with the pharmacy where they could try to maybe just give them 1 pen at a time, because 1 pen can be good outside of the refrigerator depending on the insulin you're using for anywhere from like 28 to 42 days. So you can maybe even just say to the pharmacist, can you just give them 1 pen at a time as opposed to giving them 3 or 5. Mm-hmm. So you have to be creative.
Yeah, so how do you develop these creative solutions?
Well, when you take care of people that are underserved, you just have to really think about things. You rely on talking to your other colleagues. And sometimes the patients will come up with ideas. Sometimes it may be, even though the patient doesn't have a place of their own to stay, they may have a friend or a relative where they could store their insulin temporarily, even though they're staying in the shelter system, or they may be sleeping in their car, unfortunately, or staying on the street.
So it sounds like collaboration is
Absolutely.
a piece of it with the patient and your colleagues, thinking
Support
creatively.
system.
And it feels like you're taking on like a little bit of a radical responsibility here too, because I feel like some people could say, my job, correct me if I'm wrong, my job is to diagnose, write you the prescription, and go to the next one.
Well, we also took an oath, do no harm.
Yeah.
And if we're not addressing this and we're just like, oh yeah, you're undomiciled, I can't, really help you out there, then we are doing harm because we're ignoring the fact that their medication could potentially go bad and then it's not going to work.
So this is interesting what you're saying. You're actually saying that not taking action is also harm.
Absolutely.
Because a lot of times we think that harm is like if you take an action.
Yeah, but neglecting to address these things is just as bad as, like you said.
Yeah, so you're taking that oath like radically responsibly, it seems like. So tell me a little bit more about how psychiatry influences your work with diabetes.
So we know that there is a lot of overlap between the two. So having depression can increase your risk of diabetes. Unfortunately, when your depression is not well managed or well controlled, you are not going to be as sedentary as you should be. You're not going to eat in a way that you should eat. You're not going to sleep well. And all of these factors can contribute to weight gain, increase inflammation, and set you up for having prediabetes followed by diabetes. The other thing is having diabetes itself can also be a precursor for mental illness. We do have a separate entity called diabetes distress, which is separate from depression. In fact, and what it says is that if you didn't have diabetes, you wouldn't feel so distressed. Whereas with depression, you would feel distressed either way. So we have a separate diagnosis for people who, again, it's their diabetes that's making them feel not so great. And there's actually surveys that we as practitioners can use to help screen patients for that, as opposed to just saying, oh, this has to be depression. So it's really important that we take the time to figure out what is this person's diagnosis. But there's this bidirectional relationship that if you have depression followed by diabetes, if you're not treating both, you can actually make both worse. And the other way around, if you have the depression followed by the diabetes, the same thing can happen. So it's really important that you have good integrative care. So it's oftentimes I have to interact with their behavioral health provider to ensure that we're improving upon their care, as opposed to working in a silo where it's just me focusing on one thing. I always look at the entire picture, and even if I'm not necessarily managing their psychiatric illness, I still will give them recommendations. And I can give you an example. I had a patient, he has HIV, diabetes, and bipolar disorder, and he was treated with a medication which is known for a lot of weight gain. And we have guidelines that say if someone gains 5% or more of their weight from psychiatric medication, we may want to reconsider using that medicine in certain cases. Sometimes you have no choice because it may be the only thing that works to control their mental health issues. And this particular patient gained 40 pounds in about 3 or 4 months. Now, sometimes when we hear that, we think patients are exaggerating, but the beauty of having an electronic record is you can actually go back and see. And I actually sat down one day and I went through and I looked and I saw that he was absolutely right. And this is someone who had already lost quite a bit of weight a few years ago because he had a gastric bypass. So to make a long story short, I went to him and I said, look, I'm not managing your bipolar disorder, but I think you need to have a conversation with your psychiatrist about the fact that this medication has caused a lot of weight gain, and you need to sit down and think about the risk of continuing this medicine versus the benefit of it for your bipolar disorder. And so sometimes it's not so much that you make the change, but you're empowering the patient and giving them the tools so they can talk to their other provider to make the change. And so with that, I also got him on medication that helped with his weight loss and his diabetes. He ended up losing all that weight.
Wow.
And he's only now on one medication. At first, we had to put him on insulin because his sugar was so out of control. But not only did he lose the weight, but he also is now only on that one medication. He's off of insulin. He looks better. He feels better. He also has really bad heart disease. That's well controlled. His HIV has been well controlled. And so it's just been really helpful. He also had a history of polysubstance use disorder. And there is some data showing that some of these newer medications may help with some of that as well. So he's definitely in a much better space. But again, it takes that listening and understanding the importance of knowing both the medical condition and the psychiatric condition.
Yeah. So which one did you start off with, or did you do all of the training all at once?
So I did Med-psych. It's a 5-year combined program. I trained at Rush University Medical Center. Unfortunately, the program closed in 2012. And so the way our curriculum was is that sometimes we were doing medicine, sometimes we were doing psychiatry. And so we would go back and forth. So we did adult psychiatry, we had a year of child psychiatry, and we also did adult medicine.
Wow. So you're so informed.
Yeah, so after 5 years, I was done with both. So I was board eligible for psych and medicine when I came out. I took my medicine boards, I took my endocrine boards. My psych boards I did not take, but I was eligible to take them.
Yeah.
After 2 board exams, it was enough, and it's very expensive, and it's very time consuming.
Yeah, but you have the knowledge and
Absolutely.
the training.
It makes a difference because, you know, I have a lot of patients that are dealing with depression, anxiety, and they're not always getting better because someone's put them on medication that's not really effective. And again, it's that listening and conversation. Because on the primary care side, they're not trained the same way as you're trained when you do actual psychiatry. So their armamentarium's a little bit more limited compared to what we had in doing both medicine and psychiatry.
Yeah, wow, that is really cool. So, I mean, how does it feel to you when you're able to, do you feel like a detective sometimes?
Absolutely. Absolutely. You do have to be a detective.
Solve the mystery.
Absolutely. And I think one of my biggest detective works right now has been trying to figure out what to do with perimenopause and menopause. Because a lot of women are going through it, me included, and no one tells us about it. No one really studies it. You know, they did all this research trying to find cures for erectile dysfunction, like, you know, we have all these medications. But for women going through perimenopause and menopause, there's very little known. You know, first it was take hormonal therapy. Then it was, oh no, hormonal therapy is not good. Then they went back and looked at the data and realized, oh, that population of women tended to be obese, have metabolic syndrome. We can't really extrapolate that for all women. So you know what? We can go back to using hormonal therapy to help women get through menopause. So that's definitely been something to me that I feel like we have to do a lot of detective work because there haven't been a lot of great studies looking at women's health in that area of time.
Yeah, and that gets right into kind of the equity issue
Absolutely.
too.
Absolutely.
So tell me about your journey with that.
So, health equity is something that we all strive for because all of us are coming from different places in life. So for me, I have the advantage of being very well educated. At this point in my life, I'm in a higher tax bracket than I was growing up. And so I have access to things that I didn't have when I was growing up. And so that means I can do a lot more with that. And for a lot of our patients, they may not have that. I mean, people have health insurance, some people don't have health insurance, and all health insurance is not the same. Some health insurances will cover medications easily. People can go to any pharmacy. I don't have to do a prior authorization. Some of my patients, I have to do prior authorizations every 6 to 12 months, and they can only go to a certain pharmacy. So that alone, that access to just getting medications is already one headache. And then let's talk about access to care. So one of the things that came out of COVID that was great was that telehealth was no longer restricted to the rural areas. But unfortunately, CMS is now saying that after January 30th, we're going back to the old way of doing things. So no more telehealth for people in urban areas. So it's just back to rural, with the exception of behavioral health. And that's going to be a real issue. Because again, I have a lot of patients that work multiple jobs, that have childcare or caregiver duties, so they cannot just readily come into the office. We also have not the greatest transportation. Even though New York City has buses and trains, if you live in certain parts of New York City, transportation's amazing. But there's definitely inequities in transportation for people in the Bronx. If I drive to work, I can get to work in 20 minutes. And I have a car, so it works out. But if I didn't have a car, it would take me 90 minutes. Because I have to take 3 trains. One of the trains runs really local. And then I would have to walk a mile or take a bus a mile or take a cab a mile. So these basic inequities that people have to go through just to live and survive, they carry on and carry over into their health. So if we're not thinking about these things and we're just like, oh, this patient's a no-show, they never show up, we use these words like, oh, non-compliant, we're not really getting to the root of where the issues lie, and you will never have health equity if we don't look at these social drivers: access, transportation, telehealth. Even within telehealth, some people don't have access to Wi-Fi. Luckily, New York City has a program for low-income residents in which you can get Wi-Fi for next to nothing. Some of the housing projects that we have, that's where low-income people tend to live, have been wired. You can go to local libraries. But these are some of the basic things that everyday people have to deal with, and it prevents them from getting good health care.
So, I mean, what is the rationale for removing telehealth?
Medical fraud.
Oh, okay.
But, I mean, you can have fraud in the rural areas just the same. And I'm not saying that rural America doesn't deserve to have telehealth. Don't get me wrong. Because we know there are much fewer doctors in rural America. And unfortunately, with this new change in the $100,000 for an H-1B visa, it's probably going to get worse because we had a lot of the foreign doctors that were filling these voids in rural America. We do know, especially my health system, is that we do need to close these gaps in health inequities. So my affiliation with Albert Einstein College of Medicine is pretty cool because Albert Einstein specifically said, I'm giving my name to this medical school because I believe in social justice. He was very, very adamant about the fact that if my name is to be attached to this medical school, there has to be a commitment to social justice and helping close these gaps and inequities in care. And he often worked with other civil rights leaders during his time to actually work on addressing some of these issues and speaking out against the injustices that you see in minoritized populations. So in order for us to do that, we need to not only look at what are the disparities, but we also need to figure out how to close them. And these inequities are affecting all types of minoritized communities. Very often we focus on racial and ethnic because that's what people can see. Those are the obvious ones. But we also need to consider gender, sexual orientation, disability status. So people who are able are more likely to have better access to care and compared to those with disabilities. So we have to look at all these other layers of people. It's not just so much race and ethnicity, but a lot of people will have multiple things that will increase. So the more minoritized you are, the more likely you are going to deal with inequity. So our people who don't speak English, or who might speak English as a third, fourth, fifth language. People have low health literacy, which is not the same as literacy itself.
Yeah.
So you may have someone who doesn't read very well, but they have a good understanding of the health system. I tell people you can't assume that someone who's highly educated knows more than someone who's not. Because some of the people who may be a high school dropout, high school diploma, some college, they might have been caregivers their whole life. They may be that person who went with abuela or whoever to the doctor and translated and have a better understanding of the healthcare system than someone who's got formal education. So these are all the things we need to consider when we think about inequity in healthcare.
Yeah. So what do you think? I mean, there's obviously so many areas, so many gaps, so many disparities, so many, you know, puzzles to solve, you know, but what do you think is like the heart of solving these?
The heart of solving it is always doing a needs assessment. So what is it in your population that really needs to be addressed? So for us, we realized that within our health system, we have multiple hospitals, but we have 3 big ones in the Bronx. And we actually did a 5-year chart review, and we found that, the rate of amputation for people with a diabetic foot ulcer was 44% when we looked at a 5-year period. And that was based on the billing code for having a diabetic foot ulcer with type 1 or type 2 diabetes. That's a lot. And we know that amputation often means disability. It also means that someone's going to be dealing with depression. It also means loss of income because they're not able to work. It also means maybe a fracture in the family because you used to be the provider and now you can't work any longer. I've seen that. And that loss of pride can actually take someone out. And unfortunately, once we get to below the knee or above the knee, 50% of those patients will not be with us in 5 years.
Whoa.
So based on all of that, myself and one of my partners in infectious disease, we said, you know what, we're going to do something about this. And we looked in the literature, and one of the things that works well is limb preservation. So limb preservation means we catch vascular disease early so that what happens is these patients will get good blood flow. So God forbid they do get an ulcer, the blood flow to get the antibiotics and all the nutrients they need to heal will happen. So that's one thing you can do. But also what we did is we had what's called a multidisciplinary clinic. So multidisciplinary means it's not just me as the endocrinologist. I have my partner in infectious disease. I have my vascular surgeon. I have my podiatrist. We also have a behavioral health specialist. So we have a psychologist because we know that these patients tend to need antibiotics for treatment. They tend to need surgical intervention that's not necessarily an amputation. It could just be getting some of the ulcer, the dead skin off that we don't need by either podiatry or vascular. Also, again, that limb preservation where they're going in to make sure that we have good blood flow, as well as behavioral health, because a lot of these patients will have depression, anxiety, PTSD. So we all work together in this clinic. We meet once a month to try to help our patients. So that's also one of the things to do, is not to silo their care so they have to go to all these different appointments, because a lot of these patients aren't even supposed to be walking. They're supposed to be healing. So having them come in where we all are has definitely made an impact, and we're actually now about a year into it, so we're starting to look at the data.
Wow. So you're kind of using a different model, a more collaborative model.
Yes.
Is this considered collaborative care?
Absolutely. It is. And again, it's not putting psychiatry over here or behavioral health over here and medicine over there. We're coming together, as well as with the surgeons. So it's 3 different groups of folks coming together to try to improve care.
That's awesome. So what's the cost of not addressing these problems?
Right. So the cost of diabetes care could be like $9 to $15 billion. And most of it, believe it or not, goes to this diabetic foot ulcer epidemic that we're not talking about. So a lot of times people talk about blindness because diabetes is the leading cause of blindness. A lot of times people talk about dialysis because it is the leading cause of kidney failure, but we're not talking about these amputations. And again, if I lose my leg, I'm 50, I've been the caregiver, I'm going to be depressed. I'm home. I have one patient that was able to go back to work, but that particular patient has a job where he's sitting at his desk most of the time, and he's from a much more affluent background. But for my patients that have jobs that are like more menial or they're on their feet all day, they can't go back to work. Like I had a patient who was a plumber. He couldn't go back to work.
Yeah.
He can't. He lost one leg. The surgeon said, stop smoking or you'll lose your other leg. He lost the other leg. Yeah. And I'm sorry, but I don't know how you pull yourself out of a depression when you've lost both of your legs. You can't work anymore. Your wife is now the caregiver, and you're 53 years old.
Yeah.
I mean, all the antidepressants and therapy in the world. And he told me the only vice I have, the only thing I have that brings me joy at this point is smoking my cigarettes. So
what are you going to do with that?
yeah. I mean, and that's why you have to like listen to people and try to meet them and understand where they're coming from. It's not an easy situation. And having 2 prosthetic legs, it sounds like, oh, it's not that simple. If you lose 5 pounds, gain 10 pounds, and your weight's fluctuating, those legs may not fit as well. People can get infections from the stumps, and you have to have a good amount of upper body strength. So it's not as simple as, oh, just get a prosthesis, you'll be fine. And if you're in a wheelchair and you live in a house with stairs, that's not always easy to navigate.
No.
You know, older houses don't necessarily have a wide enough door frame to get in and out in a chair.
Yeah.
And unless, like I said, if you have good upper body strength, you can't lift yourself up. And so it's a lot. It's a lot that we take for granted.
Yeah. So you've been talking about some really dire situations in this interview with me, like diabetes patients that don't have refrigerators to store their medication, and people getting amputations and not being able to get up the stairs, and so many. I mean, how do you take care of your own mental health while seeing all of this?
I think the most important thing is, for me, is to try not to get diabetes. So I'm the child of someone with diabetes, the grandchild of people with diabetes, a cousin. So like I said, it runs on both sides of my family. So for me, my whole thing is I have to eat a certain way. I work out to try to avoid having diabetes one day. And so that's also good for my mental health, because exercise really brings me joy. It helps ground me. And I like working out in the morning. That's when I'm most energized. And then also when I get to work, I'm just kind of like at peace. So it takes a lot to really stress me out, because I've already gotten my endorphins in the morning. And I like to mix it up. I lift weights. I do some yoga, stretching. I was doing Pilates at one point, which was great too, but I haven't done it in a little while. But I think that you have to find for yourself what can help bring you joy. Being outdoors, like being outside today, was amazing. I love the sun.
Isn't that interesting how just something so simple?
Yes. So you have to find what that simple thing is that brings you joy.
Yeah, I think the sun is huge. And for me, the sky.
Yes.
I like to look at the sky, because we're always focused here or something really close. Just getting out and like widening the perspective. And these are all free things.
Right, exactly,
Right?
exactly. Yeah. And I was at a talk not too long ago, and the speaker said, for those of you who live in urban areas, once a month you need to go to the country. And it's funny, because I actually started doing that. Growing up, I went to school in an affluent area, and I remember the kids always had country houses. We didn't have a country house. You know, my family was middle class, but we didn't have a country house. And I said, when I grow up and I have money one day, I'm gonna buy a country house. And that's what I did. And I'm telling you, going to the country once a month, there's something very therapeutic about that.
Oh, that's nice. Yeah. And so what is your overall viewpoint? You know, do you feel optimistic? Do you feel scared? Like, do you have hope?
Absolutely, because I always say, for every negative story I tell, there's always positive stories. And so it's funny. So my dad has diabetes. He got it when I was in high school. So people are always probably like, they're always like, oh, you must have good care because your daughter. No, actually, it was my dad. And my dad's motivation for taking care of it, and he's been on one pill his entire life, never been on insulin. He has a little neuropathy, he has heart disease, but heart disease is something that runs in his family pretty bad, so I won't blame it on the diabetes. But one of the things that he said was, my motivation for taking care of myself, and you'll see the irony of this whole story, is that his first cousin, who was in the military, so he had good insurance, he was a bilateral amputee. And my dad said, I never wanted that to happen to me.
Yeah.
And so my dad always took care of himself. My mom, when we first found out, she said, we're all changing. So the entire house had diabetes. So my dad never had to feel isolated. And so again, when I see patients like this, I always tell them that you have to be a support system. And especially if for the children, I said, we're at increased risk. So we have to learn how to eat and take better care of ourselves too. And so I think that if you have a good family support system, it makes all of the difference in the world. I remember seeing a patient once, and he talked about the fact that his wife went to Kentucky Fried Chicken, had bought a whole bucket of chicken and biscuits for the family, her and her kids, and then she gave him a salad. And she's like, well, I said, no, that's not fair, because now you're making him feel like he's different. Yeah. And I said, you know, if you want to take the kids when he's not around, that's fine. But I said, you're a family. Yeah. You have to eat together as a family. That's traditionally what most of us culturally do. You come together at the table to eat together, not to eat separately. And he was like, thank you. He's like, you don't know how hard it was for me not to just reach over, you know, and grab something. And I was like, I understand. That was very cruel. And, you know, his wife wasn't trying to be, she in her heart of hearts, she was doing the right thing. Yeah. But she then realized that it was cruel to do that to him. Yeah. So it's really important that the support system supports people with diabetes, with mental illness, substance use disorder, because if they don't feel supported, it's going to make it really hard. So it's really important that we are supportive to our loved ones, our significant others, our friends who have, you know, like I don't judge. I have a good friend who has type 1. If we go out, I'd be like, are you okay? I'm like, you're a little pale. Is your sugar okay? But, you know, I'm there more supportive as a friend as opposed to trying to be the doctor.
Yeah, so you're taking just a humanistic approach to it,
absolutely,
really.
Because it could happen to any of us, and I wouldn't want to be treated differently. So you have to sometimes put yourself in their shoes. And I feel for, like, she's constantly having to look at her glucose monitor. She has to walk around with soda. We have to go to the store sometimes and get candy for her. It's a lot, you know. So I really have a lot of compassion for people who have to live with this every day. It's a lot.
Yeah, wow. Well, thank you so much for sharing all of your incredible insights with us. It's just so encouraging to know that there's people out there like you that are taking such a wide view and like seeing how intricately connected all of these things are. And then you're also teaching this and exploring things and solving riddles and expanding, you know, your reach. So thank you for the work you do.
Thank you.
And thank you for sharing it with us. If people wanted to learn more about the work you're doing or connect with you, what would be a good way for them to do that?
So you can follow me on Instagram. It's Dr.Savalimb, like Savealimb. Yeah, we have some videos on there. So that's definitely a way to reach out.
Beautiful. Thank you.